Good morning to all of you. Today we are going to discuss about an important topic regarding diagnostic methods of myocardial infarction. As we all know that the lifestyle diseases are more common in Kerala, in that acute myocardial infarction is more commonly occurring in Kerala. So, it is very much important that we should understand the diagnostic method and we should understand the myocardial infarction at the earliest to reduce the myocardial injury and to protect the myocardial tissues. Objectives of this session are define myocardial infarction and explain diagnostic measures of myocardial infarction. Then, as we all know that myocardial infarction means it is the death of portion of myocardial tissues due to lack of blood supply. The most common cause of this decreased blood supply is due to atherosclerosis. Then definition of myocardial infarction. It is the irreversible myocardial injury and necrosis as a result of prolonged myocardial ischemia. As you can see this picture, this is a right coronary artery. In that one plaque formation is there. Because of that, the blood supply below this portion is reduced, and because of that the cardiac tissue is not getting adequate blood supply. So, the necrosis and death of the tissue has occurred. Next we can see the diagnostic methods of MI. First one, history and physical examination, ECG changes, elevated cardiac enzymes, radionuclide imaging and angiography. These are the main methods we are using to diagnose MI. In that physical examination, history we should assess the history. In history we should collect the underlying causes of MI, whether the patient has any history of diabetes mellitus, coronary artery disease and hypertension, and also we should inquire about the history of any familial history of myocardial infarction in that particular patient. Then next one, we should inquire about the clinical manifestation. In that important one is chest pain. The characteristics of chest pain we should assess. In that we should assess whether the chest pain is severe and it is not relieved by rest or position changes or nitrate administration. And the location of the chest pain is also important. The location will be substernal or retrosternal. That means below the breastbone the patient will have the pain. Then another one is epigastric pain. Most of the time the patient complained it as heartburn. Then next one is, next character is it is a radiating pain. So this pain will be radiating from it starts from the left side of the heart and it radiates to neck, then jaw, then towards the hand till the arms the patient may have the pain. Then the PQRST assessment of chest pain. In that first one is P, it indicates precipitating events. In that we should assess what are the precipitating factors for pain, whether it is the patient has any history of strenuous activity or stress. The next one is quality of the pain, whether the pain is dull, heavy or crushing pain. The next one is the radiation of pain. Radiation of pain means whether the pain is radiating to the neck, jaw and arms. Then severity of the pain, whether the patient has severe pain, mild pain or moderate pain. Then timing of the pain. When the pain is started we should inquire, and whether the pain is acute in onset or chronic. So from that we can identify whether the patient has a cardiac chest pain. Then next important diagnostic measure is ECG changes. So in ECG the ST segment changes are very much important. So what is ST segment changes? What is ST segment? So from this ECG we can identify that ST is the ST segment means it is the starting end of the QRS complex and starting of the T wave. So normally it is a isoelectric line. So in case of MI or in case of infarction or ischemia, the ST changes will occur. So ST segment elevation will occur in case of infarction. So, in the second picture we can see the ST is elevated from the normal line, that is ST elevation. Then next one is ST depression. So, ST depression means ST is below the isoelectric line. Then next change is T wave inversion, and another one is pathological Q waves. So, these are the changes, ECG changes we can see in case of MI. First one is ST elevation, ST depression, T wave inversion and pathological Q waves we can see in ECG. Then changes occurs first in ST segment, then T wave and finally the Q wave. When the Q wave changes has occurred, it will be lifelong. That change will not be revert back. Then location of myocardial infarction. From ECG we can identify which location of the heart has occurred the MI. Then from that, from the 12 lead ECG we can identify this location. So, lead 1 indicates lead 1 AVR, AVL, V5 and V6 indicates lateral infarction. Then 2-3 AVF indicates inferior wall MI. Then V1, V2 indicates septal MI and V3, V4 indicates anterior wall MI. From this location we can also identify we can also assume that which coronary artery is affected or blocked. For if the patient has anterior MI, anterior wall MI, the coronary artery, most of the time the coronary artery affected is left anterior descending artery. In case of septal MI, left anterior descending artery, in that septal branches are involved. Then in case of lateral MI, left circumflex artery or obtuse marginal artery will be affected. In case of inferior MI, the patient diseased artery is RCA, right coronary artery or right circumflex artery. In case of posterior MI, right circumflex artery. Then right ventricle MI, right coronary artery will be affected. Then atrial MI, right coronary artery will be affected. So, from the 12 lead ECG we can identify which area of the heart is affected, and also we can assume that which coronary artery is diseased. Then blood investigation. Next one is blood investigation. In that, first one is creatine kinase. Creatine kinase is an isoenzyme which is produced from the cardiac cells, and it is released within 2 to 6 hours after the onset of myocardial damage. Then it is peak in 12 to 18 hours and return to normal level within 3 to 4 days. And it is not much specific to cardiac injury. Other conditions can also produce this creatine kinase. The next one is troponin. Troponin, it is a cardiac enzyme which is released from the cardiac tissues. Then it is rapidly released into the peripheral circulation in proportion to myocardial damage. So, according to the myocardial damage, the amount of troponin also will be increased. Then troponin, mainly 2 types of troponin are using for cardiac diagnosis. One that are troponin T and troponin I. Troponin T is same like creatine kinase. Then troponin I, nowadays we are most commonly using troponin I for diagnosis. Then troponin I, the levels increase 7 to 14 hours after acute myocardial injury. Then it remain present for 5 to 7 days and providing a broad diagnostic window. Then it is not affected by any other disease or injury. So, it is cardiac specific. So, it is very specific and sensitive test to identify acute myocardial injury. Then next one is myoglobin. Myoglobin also is a heme protein found in striated muscle fibers, and it is rapid release detected within 2 hours after acute myocardial injury. Then other factors also influence for the release of this myoglobin. So, it affected by strenuous exercises and heavy ethanol uses. So, in that cases this myoglobin will be released into the bloodstream. So, it is highly sensitive indicator if serum levels double when second sample is drawn within 12 hours of first sample. So, it is also myoglobin is also not a specific cardiac specific test. Then lactate dehydrogenase. It is an isoenzyme in cardiac muscles, then it elevates to 14 to 24 hours after onset of myocardial damage. It is peak within 48 to 72 hours, then return to normal over 7 to 14 days. Then aspartate transaminase. So, it is a serum, it is also a isoenzyme which is produced from the tissues. So, these serum levels increase within several hours after the onset of chest pain, then peak within 12 to 18 hours, then return to normal within 3 to 4 days. It is also not a cardiac specific drug. Other disease condition can also cause to release this enzyme into the serum. Then leukocytosis. So, it appears on second day after acute myocardial injury. So, the releasing time is very long. So, in case of acute MI, immediately it is not able to, it will not help us to diagnose the disease. Then it disappears in 1 week. Next is so, in this graph, which from this graph we can understand that the troponin is the best cardio biomarker to diagnose the MI. So, in this graph we can identify troponin immediately released into the bloodstream within 3 to 12 hours, and it peak in 2 to 3 days, and after that it will return to 5 to 14 days from the blood. Next are radio imaging studies. So, in that first one, an important one is echocardiography. So, in echocardiography we are using sound waves to know the motions of cardiac walls and cardiac structures. So, it helps to assess the ability of the heart walls to contract and relax. That means it helps to assess the movement of the heart walls and valves. Then wall motion is abnormal in case of ischemic conditions. So, in case of ischemia, the wall movement will be decreased, and in case of severe infarctions, there will not be any movement of that particular wall. That means if in case the patient has anterior wall MI, the anterior walls will be akinetic. Akinetic means there will not be any movement in that particular wall. So, the contraction and relaxation of that wall will not be present in case of ischemia. Then we can also identify the valvular functions and chamber size, thickness of the muscles. These things also we can identify through echocardiography. Then magnetic resonance imaging. So, to identify site and extent of MI, then assess effect of reperfusion therapy. It more commonly using to assess the effect of reperfusion therapy. Then next one is positron emission tomography. So, it helps to evaluate cardiac metabolism and assess tissue perfusion through the imaging studies, and it is a non-invasive procedure. So, accurately we can identify the tissue metabolism in the cardiac tissues. Then assess the coronary artery flow reserve and detect acute myocardial injury. So, these are the diagnostic evaluation radionuclide imaging studies for MI. In that, most commonly we are using echocardiography. Then next one is coronary angiogram. So, as we all know that it is a common term, angiogram. Most of the cardiac patients they may undergo coronary angiogram. So, it is the procedure that uses X-ray contrast to look at the coronary arteries. So, in that we are introducing a catheter to the heart, to the coronary arteries through either through the radial artery or through the femoral artery that catheter is inserting, and it will reaches to the heart and till the coronary arteries. There we are injecting. So, here we can see the catheter which is entering into the coronary artery. So, there we from when it is reaching into the coronary arteries, we are injecting dye to the coronary artery and we are taking the X-rays. Through that X-rays we can identify which is the artery is affected or blocked or diseased. So, it is the most accurate test to diagnose the percentage of block in the coronary artery. So, we can identify how much percentage of the coronary artery is blocked and how much restriction or ischemia is occurring to that particular cardiac tissue. So, this is the image of the coronary angiogram. So, this is the right coronary artery and this is the left coronary artery. So, from that we can identify whether the which coronary artery is affected, whether it is affected by the left coronary artery or right coronary artery, and what percentage it is reduced its blood flow. So, as conclusion, so diagnostic measures are very much important in cardiac diagnosis. So, as at the earliest we should understand the disease condition. After that only we can diagnose the particular disease condition. So, as the earliest we are able to identify MI, then we can reduce the myocardial injury. So, time is the muscle in case of MI. So, I hope all of you understood this session. Thank you.